Vanakkam. When it comes to phalangeal base fractures, it is always a mystery. Whatever you do, whether you put a splint or whether you do a traction or whether you put plates and screws, invariably there is going to be stiffness and edema. Is there absolutely no way in which we can get good results? Whether it is base of the middle phalanx or base of the proximal phalanx? It is a little difficult, but we can always try. And when we try, we need to use the correct techniques and the correct methods. In this video, we shall learn all about the management of phalangeal base fractures, mainly of the middle phalanx, and also learn about techniques like the Aluminium splint traction, Suzuki's dynamic external traction system, and also the pencil method and the 90-90 method of reduction of Physeal fractures. When dealing with phalangeal base fractures, we should be dealing with the base fractures on the terminal phalanx, middle phalanx and the proximal phalanx. But we have already dealt with base fractures on the terminal phalanx in a couple of earlier videos, one which deals with volar base fractures, as there are fracture fragments present. These bone segments can be attached, and one which deals with dorsal base fractures. Along with the pull-out suture and anchor suture, we have the extra option of you can click on the icons above to access the videos. We shall be dealing mainly with base fractures on the middle phalanx and to a certain extent proximal phalanx in this video. First, let us understand a simplified anatomy of the base of the middle phalanx and the proximal interphalangeal joint. Around this joint we have the joint capsule, and on the dorsal aspect we have the insertion of the central slip on the base of the middle phalanx. On the volar aspect we have the insertion of the flexor digitorum superficialis, which is just a little distal to the base. On both sides we have the proper collateral ligament that runs from the side of the PPX head to the base of the MPX, and the accessory collateral ligament that runs from the side of the head of the PPX to the joint capsule. Fractures of the base of the middle phalanx can be partial fractures, which could be volar base fractures, dorsal base fractures or lateral base fractures, or complete base fractures, which are otherwise known as Pilon fractures. A formal classification of these fractures was proposed by Seno et al. In 1997. According to this classification, Type 1 referred to volar base fractures of the middle phalanx, Type 2 referred to dorsal base fractures, Type 3 referred to both dorsal and volar base fractures, something similar to the Pilon fracture, Type 4 referred to metaphyseal fractures of the middle phalanx, and Type 5 referred to lateral base fractures. But the two most clinically important types are the dorsal base fracture of the middle phalanx and the volar base fracture of the middle phalanx. Let us study these dorsal base fractures first. This type of fracture is usually associated with a hyperflexion injury, and there is an avulsion of the central tendon along with a segment of the bone. If the avulsed fragment is displaced more than 2 mm and boutonniere deformity presents, it will require accurate reduction and internal fixation or percutaneous pin fixation. The volar base fractures of the middle phalanx result from hyperextension injury or axial loading. It represents avulsion of the volar plate with a chunk of bone on the volar base. It is considered unstable if more than 40% of the articular surface is involved. This type of fracture of the volar base of the middle phalanx is associated with the dorsal subluxation due to the pull of the intact central slip. So when the patient tries to flex the PIP joint, instead of the base of the middle phalanx gliding over the head of the proximal phalanx, it just hinges and jams at the head of the proximal phalanx. Fractures of the lateral base of the middle phalanx represent avulsion of the collateral ligaments. Now let us consider the complete base fractures or the Pilon fractures. These fractures are unstable in all directions and they are the result of axial load that causes central articular depression and variable splay of the articular margins. Typically, they can occur in two configurations: as centrally impacted comminuted fractures which are caused by compression, or with a T or Y type fracture geometry typically caused by avulsion injuries. We need to remember here that compression fractures are not reducible by ligamentotaxis, as the centrally impacted fragments are devoid of soft tissue attachments, so direct reduction is often necessary, whereas avulsion fractures respond to ligamentotaxis and traction is one of the methods of management. The aim of treatment in such Pilon fractures is to obtain stable fixation, to allow early motion and to minimize the risk of later degenerative joint disease. Whenever a basal fracture of the middle phalanx is suspected, X-rays, that is PA view, lateral view and oblique views must be obtained. Just one view may not help at all, as you can see in this PA view and the lateral view which shows the subluxation of the PIP joint. There are two important radiological signs to indicate even very minimal dorsal subluxation in volar based middle phalangeal fractures. One is the dorsal V sign, which indicates the hinging rather than the gliding, and the line indicating the dorsal cortex of the proximal phalanx will not be in the same line with the line indicating the dorsal cortex of the middle phalanx. This also indicates dorsal subluxation at the proximal interphalangeal joint. A CT scan will also be useful in imaging of middle phalangeal base fractures to assess the articular involvement, to assess the amount of articular displacement and the degree of comminution. We need to concentrate on three important points in the management of such fractures. The first is achieving a perfect reduction of the displaced articular bone, and alongside we need to achieve edema control. Let us see all the options we have available for the management of middle phalangeal base fractures, starting from reduction of the fracture, immobilization and splinting, open reduction internal fixation with K-wires, plate and screws, lag screws, traction which could be static traction or dynamic traction, and also two techniques of arthroplasty, Volar plate arthroplasty and Hemi Hamate replacement arthroplasty. We shall see the details about each of these methods now. Reduction, immobilization and splinting is indicated in open injuries with a precarious viability of the finger or if resources are limited. The technique of applying splinting is immobilization in lumbrical position with the proximal interphalangeal joint straight for 3 to 4 weeks, and after that, when mobilization is started, we need to provide a straight splint support when not mobilizing. This technique of management is not very predictable, as the reduction of the dislocation may not be achieved and pain will be a limiting factor during mobilization. In this example, immobilization and splinting was done for the middle phalangeal basal fracture with fair results. The use of K-wires for internal fixation after open reduction of middle phalangeal base fractures is indicated for open injuries, especially extra-articular fractures. But the problem is it is not possible to start early mobilization because it may lead to loosening of the wire. So 3 weeks of immobilization is mandatory. The advantage of using K-wires is that it is not retained. This clinical example shows a patient with a fracture of the base of the middle phalanx fixed with a K-wire. Plate and screws can also be used for internal fixation. It consists of exposure, disimpaction of the fragments using either a K-wire or a dental pick,
and then ensuring the congruity of the articular surfaces. If a cartilage step off greater than 1 millimeter is present, it may lead to degenerative joint disease. A void will be created by the disimpaction. Leaving this void as such will create two disadvantages. One is there will be an unstable situation because the fragments may easily redisplace or collapse, and secondly, the healing process will be delayed. So cancellous autograft must be used to fill the impaction void, and a graft will also enhance the healing process. We have a choice of three types of plates available for management of such fractures: 1.5 mm mini condylar plate, 1.3 or 1.5 mm L plate known as the adaptation plate or T plates. For fixation of small fracture fragments, hook plates can also be used. Lag screws are very effective in the management of some volar base fractures or dorsal base fractures. The principles of lag screw application have been discussed in an earlier video, and you can click on the icon above to access that video. Since impaction of the bone is the feature of complete base fractures or pilon fractures, traction will help to maintain the articular surface. This traction can be in the form of static traction using nail plate traction or dynamic traction in the form of skeletal traction. Skin or nail traction is based on the principle of ligamentotaxis. It is indicated in pilon fractures which are closed injuries and when limited resources are available. The technique of applying this skin or nail traction is as follows. First, we need to apply a Volar wrist slab. Then we incorporate a long aluminium splint with a 90-degree bend at the metacarpophalangeal joint. Next, we apply again another wrist slab and then wait for it to set. We mold the splint to bend dorsally 3 cm distal to the fingertip. Now we apply a traction stitch on the nail plate under local anesthesia using 3-0 polypropylene suture, and then anchor the traction stitch around the bend in the splint. We need to check the viability of the finger and take a check X-ray to ensure that the traction is adequate. This clinical example shows a long aluminum splint traction being applied for a basal fracture of the middle phalanx of the little finger and the ensuing results. The use of skeletal traction or external fixation is very appropriate for middle phalangeal base fracture management. It is ideally applied as dynamic external fixation. The static traction external fixator was introduced in 1946. A very elaborate dynamic distal traction splinting and early mobilization was introduced in 1986, and the compact and dynamic traction external fixator device with an early protected range of motion and good reduction of the fracture was introduced by Suzuki in 1994. It is ideal for dorsal base or volar base fractures. Let us see how this fixator is applied. Under digital block anesthesia, first a 1.2 mm K-wire is passed transversely through the head of the proximal phalanx of the involved finger. This is bent on both sides to run parallel to the length of the finger and projecting beyond the length of the finger and turned to form a hook that faces distally. Next, a 1 mm K-wire is passed transversely through the head of the middle phalanx. This is also bent and runs distally parallel to the finger, and at the two ends a hook is formed that faces proximally. There should be a minimum distance of about 2.5 centimeters between these hooks and the hooks that we had applied earlier. The traction is applied in the form of a rubber band between these two hooks. This will provide the traction to pull the fragments distally. Another 1 mm K-wire is passed transversely at the middle of the shaft of the middle phalanx. which is known as the reduction wire. This wire needs to be passed volar to the axis in case of volar subluxation and dorsal to the axis in cases of dorsal subluxation. This wire will help to maintain the reduction of the dislocation when movements have started. These clinical pictures show the good results that can be obtained with such pin and rubber dynamic traction. The commonest problem is the volar base fracture because it has no significant soft tissue attachment apart from the volar plate, and the vascularity is also poor. If there is a comminution of this segment, it can be easily excised, but it may create a defect, and this will hinder the smooth movement of the proximal interphalangeal joint. Hence, there are two treatment options available in such situations: a volar plate arthroplasty and Hemi Hamate replacement arthroplasty. Volar plate arthroplasty is appropriate for unstable fracture dislocations, that is, dorsal fracture dislocations with more than 40% of articular surface involved and unsuitable for open reduction internal fixation. The technique was described by Eaton and Malarick in 1980. It consists of first removing the comminuted portion of the bone, that is, the volar base of the middle phalanx, and then advancing the volar plate through the joint and attaching it to the bone, either with a suture that is passed through a drill hole in the bone or to the lateral aspects of the bone. The joint is pinned in slight flexion and this pin is removed after 3 weeks. The attachment of the volar plate like this prevents dorsal subluxation of the middle phalanx, but the results with this technique are quite unpredictable. The Hemi Hamate replacement arthroplasty was described by Hastings in 1999. Here, the dorsal distal portion of the hamate replaces the gap in the volar base of the middle phalanx. It is rigidly fixed and early motion can be instituted. This is the shape of the base of the middle phalanx. After debridement, this would be a defect on the volar base. This shows the distal articulation of the hamate bone with the 4th and 5th metacarpal bases. This segment of the hamate can be harvested as a free graft. It is then used to substitute the volar base of the middle phalanx. On the lateral view, it can be represented like this. There are 3 main complications that can occur after management of middle phalangeal base fractures. The first is stiffness and flexion contracture, which could occur due to accessory collateral ligaments which are lax in flexion, lack of extensor power due to central slip attenuation, flexor tendon adhesions, articular incongruity, post-traumatic hemarthrosis, and poor compliance with therapy. The second complication that can occur is chronic swelling. This limits the PIP joint arc of motion, and usually this swelling diminishes over 6 to 9 months, but sometimes never completely. Patient counseling is very important, as is a compression sleeve for 6 months. The chance of redislocation or subluxation ranges from 0% to 31% according to various studies. Though not as dramatic as middle phalangeal base fractures, proximal phalangeal base fractures are also important. There are 2 mechanisms of injury causing 2 types of fractures. If there is a direct blow creating axial load to the finger, we get comminuted intra-articular base fracture. If coronal forces are applied to the finger, intra-articular avulsion fractures of the base of the proximal phalanx will result. According to the AO classification of proximal phalanx base fractures, we have proximal metaphyseal fractures which could be transverse and oblique types, and proximal articular fractures which could be avulsion type, shearing type, or multifragmentary types. The proximal metaphyseal type of proximal phalanx base fractures are extraarticular fractures which occur at the metaphyseal diaphyseal junction. They are usually comminuted dorsally only with apex volar angulation. If the reduction of such fractures is poor, malunion will result, and this may be caused due to immobilization of the digit in insufficient flexion at the metacarpophalangeal joint. This malunion will produce a pseudoclaw deformity, that is hyperextension at the fracture and hence at the metacarpophalangeal joint, and subsequently extensor lag at the proximal interphalangeal joint. Since the volar apex angulation is the cause of this malunion, we need to know how much of this angulation can be accepted. In children, 30 degrees of apex volar angulation is acceptable, but in adults, even 25 degrees of uncorrected angulation will require a corrective osteotomy later. The ideal management of such proximal metaphyseal fractures can be closed reduction and splinting in the correct position, or closed reduction and percutaneous pinning. When closed reduction and splinting is done, we need to reduce the fracture by flexing the metacarpophalangeal joint maximally to stabilize the proximal fragment and also help to relax the intrinsic muscles. We also need to correct the volar angulation by flexing the distal fragment too. Immobilization must be maintained with the metacarpophalangeal joint flexed to 70 degrees and PIP joint extended and maintained for 3 to 4 weeks. The X-ray shown demonstrates insufficient reduction. Closed reduction with percutaneous pinning under C-arm guidance can also be done. K-wire is drilled through the flexed metacarpophalangeal joint into the proximal fragment alone. Then the distal fragment is reduced onto the proximal fragment and K-wire is drilled across the fracture into the distal fragment. The proximal articular fracture is the commonest type of base fracture involving the proximal phalanx. Immobilization and splinting is not ideal for this kind of fracture. Open reduction followed by tension band wiring or lag screw or reattachment of the collateral ligament are good options. This picture shows a proximal articular fracture of the proximal phalanx of the little finger, which can be accessed by a zigzag incision on the palm. Lag screw fixation of the fracture has been done. Physeal fractures of the base of the proximal phalanx are very common in children. They are usually Salter-Harris type 2 fractures, and the epiphyseal fracture of the base of the proximal phalanx usually involves the little finger. Here a clinical picture shows a physeal fracture involving the base of the proximal phalanx of the ring finger. The angulation occurs to the ulnar side, hence it is sometimes called an extra octave fracture because it resembles the position of the little finger when plunking the extra octave key on the piano. There are two methods of reduction of such fractures. The first is known as the pencil method. A pencil is placed in the web space between the ring and little fingers when the little finger is involved with the fracture, and the ulnar deviation at the base of the proximal phalanx can be corrected now by adducting the little finger to the ring finger. The second method is called the 90-90 method, where both the metacarpophalangeal joint and the proximal interphalangeal joint of the involved finger are kept at 90 degrees and the fracture can be reduced. After the reduction, immobilization needs to be done in an ulnar gutter splint for 3 weeks. This clinical example shows a physeal fracture of the base of the proximal phalanx of the right hand little finger, which had been reduced and immobilized in a POP slab. The resultant healing of the fracture and the resultant movements are shown.
I hope you enjoyed this video. Please do click on the shown links to see more about phalangeal fractures, the head fractures, the neck fractures, the shaft fractures and so on. And do not forget to subscribe to stay connected with the latest in learning hand surgery, trauma surgery and plastic surgery.